Michelle Lott. I own Lean RAQA. We specialize in helping startups and small to mid-sized companies navigate the regulatory challenges for both the US and EU. Intended use is one of a piece of three-legged stool that we'll talk about that's critical to your technical documentation. And those three legs are your intended use, the state of the art, and adequate evidence. So specifically for the intended use, you have to have very well-defined intended use that includes indications for use. And indications imply things about which patient population, duration, location in the body or on the anatomy. All of these things between your claims and your indications can affect which testing and ultimately state of the art is applicable to your device. And one interesting twist about MDR is that they will specifically look at your marketing material and pictures on your website, and they get into what implied claims do you have even via a picture that you need to support with adequate evidence. Is kind of the foundation of the technical documentation now. It used to be the other way around where the bulk of the technical documentation was a subset of the clinical evidence. Now it's a little bit reversed. And so clinical evidence has really taken priority in the review under MDR. I've worked across probably 5 or 6 notified bodies in a clinical review, and without question, the biggest challenge is that it is now the most subjective portion of the whole documentation review, because it is 100% at the whim of the clinician that they have reviewing it, who is reviewing it from their opinion or their experience outside of a regulatory context. So that means that outside of the regulatory framework about what are the basic contents, what are the objectives of the clinical evidence, that it becomes a very subjective exercise now. State of the art is a huge component of what you're trying to demonstrate, not only from a performance perspective in your technical documentation, but it's also the whole objective of your clinical evaluation and evidence. So state of the art was just recently defined in ISO 14971. And logically, you think state of the art is the most technologically advanced. And that's not what it means by the technical definition in 14971. It's irrespective of what is the most technologically advanced, but what is the most widely accepted and recognized. And so now we have a divergence in state of the art and standard of care. And is standard of care, surpassing what a notified body may recognize as state of the art? So it's this whole life cycle that companies have to go through, where they do this dance in and out of trying to get the right clinical evidence to demonstrate their state of the art, but having something new and novel where there might not be a technical standard or common specification yet. And so they have to go through this process with the notified bodies and then the expert panels that result in the issuance of a common specification that create a new state of the art that becomes the new standard of care. So companies really need to be prepared that, most of my clients, they try to make these arguments that, hey, these are long-standing technologies. These are well-known materials. Well, now that the notified bodies are legally responsible for not only your documentation, but the safety and efficacy of your product under MDR, they're not going to go out on any limbs making assumptions or buying any type of rationale or justification. So you really have to go back and look at all, especially if you have a product that's been on the market for a long time, you need to go back and reassess all of the testing that you're going to turn in, make sure it's done to the most relevant version of whatever performance standard that governs that test, and that you haven't made any rationales that aren't supported by either other evidence or clinical literature. And an example of this is that I was challenged on, how do you know stainless steel doesn't change size or shape? And the notified body said, oh, by the way, you can't use literature from the depth of the sea or from outer space in the satellites and space stations. You need clinical applications at room temperature and humidity. That is the most interesting thing, and it's the most consistent thing about notified body reviews, is the inconsistency and how often you get these questions from out in left field. So have I only been challenged on stainless steel once so far? Yes. But I was also challenged on why I didn't have a warning on a product about caution. If you use latex gloves, the patient could have an allergic reaction, even though the product didn't come with latex gloves. The company doesn't sell latex gloves at all. The notified body says, well, you know that the user is going to use gloves, and so therefore it's a reasonably foreseeable hazard that they could use latex gloves. So I said, so are you telling me that every single device that goes into Europe, everyone is going to have to change its labels to add a warning about the use of latex gloves? And the notified body said yes. I got that one repealed because it was so illogical. The biggest challenges that people are going to be unprepared for in their post-market surveillance is the need to be proactive in gathering it. Like, it's going to be no longer adequate to just monitor your complaints and maybe improve your product based off of a complaint or a service record. Now there's an expectation that, especially if you don't have complaints, I've heard the notified bodies ask, is it because you really don't have complaints, or because you're not asking your clients if something happened with the product? So now there's going to be this expectation of not only searching, the MAUD database and upcoming modules of Unimed for adverse events of your product and other people's product, but searching other aspects of clinical literature, general chatter on the internet, and then doing surveys with your customer as well. And more than ever, it's going to move away from something that somebody can manage manually and without tools to electronically do to the level of adequacy that's going to be expected for post-market surveillance in the future. The level of ownership and teamness that companies are going to have off of their data and how they collaborate within each other is going to have to change. Now it truly does take a village to raise a technical file and clinical documentation. It is going to take your engineering team, your regulatory team, your quality team, biocompatibility expert, sterility expert. I could keep going with all the different niches and depths that you're going to need to have. So it's not going to be a siloed function anymore. And then the other thing in terms of the onus, like I said, you have to move away from the understanding of longstanding technology, just engineering justifications. Let's get out of this testing. You also have to get out of relying on test labs to tell you what is the state of the art for your product. They are not the expert in your product. And even if they tell you what to do, you are responsible for explaining why what you and or the lab chose was the right thing based off of your intended use and state of the art combinations. And then there you have your adequate evidence to support those two applications.